Hello and welcome to Alterations of the Reproductive Systems. In this segment, we're going to talk about some of the normal anatomy and physiology and then some of the abnormal pathophysiology that can occur with patients who have alterations of the reproductive systems. So let's go ahead and begin and take a look at how our reproductive systems are formed in the first place. So this slide here is showing the differentiation that occurs in our reproductive systems when a child is being developed in utero. So we have that undifferentiated reproductive system at the top and then differentiating down into the male and the female organs. Certainly you can pause at this point if you need to review any of the components of those organs just to get a kind of a little bit of background before we start talking about any problems that are occurring with the reproductive system. One of the problems that we'll start out with here is that of delayed puberty. So obviously we have the development there that we saw in a previous slide, and that development can be altered or can be interfered with in certain situations. And one of those would be in a situation of delayed puberty. We refer to this when people lack secondary sexual characteristics and they have not appeared by the age of 13 or 14. 95% of the cases are just simply a delay and not a big deal, so we're not going to rush out and try to add a diagnosis to this or treat the patient in any way. It's just simply going to be acknowledged that there is a delay in puberty. Puberty is going to affect or is going to be noticed in kids at a variety of different ages. So anywhere from 10 up to 16 or 17 would be a common range that we might see and when puberty may hit. But typically by the age of 13 or 14, we're starting to see some of those secondary sexual characteristics. There's about a 5% grouping here, so 95% are simply just going to be delayed and they are going to develop those secondary sexual characteristics, but about 5% is a person who's going to have a disruption of that hypothalamic pituitary thyroid or gonadal axis, and this is the feedback system that is providing the impetus for the sexual organs to develop and to mature. So our reproductive structures, again, you can go back and take a look at that previous picture. We're going to take a look at each one of these a little bit here is just to review the anatomy and physiology, but the normal components of the reproductive system in the female and of the male. Normal male reproductive organs, and again you can pause the slide here if you need to review what some of these are, and we are going to talk about some disease processes that affect them. One of the things that I do want to point out here is when you look at the reproductive organs, also be looking at both the intestinal system and the bladder to get a good idea, good visualization in your mind as to where these things are. Notice how low the bladder is in the abdomen. So it's very, very low. In fact, it's behind that pubic bone. So very low. If you feel on your own body, you might be able to feel the pubic bone very down low there, and that's where the bladder is. Behind the bladder, then, we have the rectum. Okay, so all of these components are in very close proximity to each other, and when we have a problem with one organ system, it can affect the other organ systems as well. For example, if the patient is having bladder problems, that can affect the patient's ability to reproduce because those organs are attached. If the patient is having problems with their intestinal system, that can also affect the bladder and can affect the urinary tract or the reproductive system as well. Inside the testes, we have just a whole bunch of vessels that are going on in there that are helping to feed the testes and hoping to be able to help that person to be able to produce sperm so that they can be used in reproduction. So again, if you need to stop the slide here for a moment and just review the normal anatomy and physiology, just so that you can keep it kind of clear in your mind as to what we're talking about when we talk about some of these disease processes. One of the main ones when we're talking about men is going to be talking about the epididymis. Okay, so that's one piece that we'd want to look at, and the scrotum itself, because we're going to be talking about some other pieces there, and then actually where the testis itself is. So take a look at those pieces in the slide and then go ahead and move on. The female reproductive tract, and again, the same way that we talked about the male reproductive tract, keep in mind where things are in relationship to each other. So you can see that, again, we have the urinary tract, but we also have the bladder being very close to the reproductive organs. So the bladder is in very close proximity to the reproductive organs. That's why in many cases, if somebody's having an ultrasound, for example, they're looking at the baby and especially in the early phases here, they're going to ask that mom to have a full bladder. The full bladder is going to straighten up and kind of press that uterus into a better position where they're able to see it with the ultrasound. So that's why they do that. And you can see how the relationship is from this slide, how close the proximity is of the bladder to the uterus. Also, notice the close proximity of the rectum and the colon, this descending colon here, so we're getting the sigmoid colon in the rectum, and how close that proximity is to the reproductive organs and to the bladder. So all these things in very close proximity to each other. One other thing that may be helpful to notice from the anatomy and physiology at this point, because urinary tract infections are more common in females than they are in males, notice how close the urinary opening is to the rectum and the vaginal opening in the anatomy. So, and that's what causes the problems with our urinary tract infections, is that the opening for the bladder, which basically is supposed to be kind of a sterile organ, is very close to the openings of the vagina and the rectum, which are non-sterile areas, and bacteria from those areas can very easily get into the urinary tract and cause urinary tract infections. The external genitalia, again, if you need to stop the slide just to review what the different components are and where they are, again, notice the very close proximity of the urethra to the vaginal opening. One other thing to keep in mind here is that at some point in time here, you're going to need to catheterize a female. And when we put a catheter into the woman's bladder, we have to stick it into the urethral opening. So notice where the urethral opening is here on this picture, very close to the vagina. We're going to move up from the vaginal opening to find the urethra, and we actually have to visualize it. Now, you're going to hear more about this later, but you actually have to visualize it before you can stick the catheter in. So we're not going to just go blindly and try and find the urethra, but very close proximity there to the vaginal opening. The structure of the breast and some of the components of the breast considered here to be part of the reproductive organs, and obviously there's some of the components here that are important as far as the ductwork, etc., in order to make milk production so that hopefully the female can be able to breastfeed. This is showing a couple things here. First of all, it's showing a little bit of the circulatory system, but probably more importantly, and what we really need to get out of this slide, is the lymph nodes. So the lymph node system here, and that's all the green you're seeing there, is the lymphatic system of the breast. And that lymphatic system is draining out into all of these little lymph nodes. You see all those little green dots kind of look like peas on your screen there. Those are all lymph nodes. Now those lymph nodes are designed so that they're going to catch bacteria, etc., and filter it out. However, when a woman develops breast cancer, we have to start looking at those lymph nodes, because those cancer cells could have migrated backwards through the lymph and gotten stuck in those lymph nodes. So that's why they will remove, or they'll test at least, lymph nodes when a woman has breast cancer, and in many cases may have to remove some of those lymph nodes. Notice there's a whole bunch of them. We've got them going up into the middle of the chest. We have them going up into the armpit area, the axilla, and up into the area by the neck. So there's lymph nodes all over the place that are draining from the breast there before they go back into the central circulation. The menstrual cycle is going to be controlled by some ovarian hormones such as follicle stimulating hormone and luteinizing hormones, so LH and FSH. And the purpose of this cycle being that we're readying the uterus to be able to have a baby, to be able to develop a baby. So that's the whole purpose, is that the menstrual cycle is readying the uterus so that it can be ready in order to be able to allow implantation and to allow a fetus to develop. But then it also cleans out the uterine lining at the end of the cycle so that there isn't this leftover component there that could be interfering with pregnancy later on in the future. So it's a continuous cycle of being able to ready that uterus so that it's ready to accept a fetus, and then to clean it out afterwards, which is what causes the bleeding in the menstrual cycle. So if you take a look at our next picture here, kind of gives you a good idea of what's happening over time. And you see down at the bottom part there, it's talking about the number of days, and we're talking about the menstrual phase, going into the postmenstrual phase, ovulation, premenstrual phase again, and then instant menstruation again. So what we're doing is we're readying the uterus, getting the eggs ready, the follicles ready, and going through this whole process of ovulation, etc., so that the eggs can hopefully be there and be ready to accept the sperm and to become fertilized and then to start to develop a fetus. So notice the different changes that are going on here. When we look at the ovarian hormone cycle in the middle of the page, you're going to see the different changes in hormones. So the estrogen goes up considerably. Later on, the progesterone goes up. We have just a lot of changes here occurring in the hormones, and that's what's causing a lot of the things that we see with the menstrual cycle. Again, at the top of the page there, it's showing something about the psychogenic influences. Well, certainly when hormones are changing in the body, there's going to be some changes that occur in how we respond to them. So the changes in hormones are going to affect mood, and that can often make people kind of irritable, etc., during different times of the cycle. The other thing to notice is at the bottom of the page there, when we're looking at the temperature cycle, notice how tremendously, or not tremendously really, but notice how much of an increase there is in temperature during that premenstrual phase. So we could monitor the patient's temperature, body temperature, to be able to predict when they're going to ovulate and when the period is going to be, to some extent. That's not always totally accurate, but that is another possibility of how that's going to occur. In the middle there, right above that temperature cycle, it talks about the endometrial cycle. The endometrium is the inside lining of the uterus. Notice how it's building and building and building, and then during menses, we're shedding that lining to some extent there so we can rebuild the lining to prepare for the next ovulation. This slide is showing the progression that occurs with the follicle as it starts to mature, as it starts to develop during the patient's menstrual cycle here. So you see the mature follicle, and then we start to see that as we move further on in, that hopefully it's going to become fertilized and develop into a fetus. Okay, so let's take a look at our questions here. Which of the following hormones inhibits follicle stimulating hormone synthesis and secretion? Well, hopefully you answered letter B. So activin stimulates follicle stimulating hormone release. Inhibin inhibits its release. So then we move on to fertilization and implantation. So we have the development of the uterine wall, and now we're getting ready for fertilization and then implantation. So fertilization is going to occur in the fallopian tube itself about 12 hours after ovulation and within 2 to 3 days of insemination. Next, implantation occurs. Now this takes about 6 to 8 days after ovulation that we're actually going to have the zygote implant on the wall of the uterus. Okay, so that's going to be a separate process that the egg is going to roll down the fallopian tube, become fertilized, and then implant on the uterine wall. Critical thinking question is, can measuring body temperature to detect ovulation be used as a form of birth control? Well, I suppose it could. It's not a very accurate method, and it does involve that the person be abstinent for a long period of time so that we're making sure that we're covering both ends here, and not because obviously the temperature is going to go up after the person has had ovulation. So we're not going to be able to really control birth control very well with this. However, monitoring the patient's body temperature might be a better way to predict when the person's going to ovulate. So it might be a better predictor of when the person's most likely to get pregnant rather than as a predictor of how to not get pregnant or to be used as a form of birth control. Some menstrual alterations include dysmenorrhea, and that can be either primary or secondary. And the dysmenorrhea is what the term means is we have painful menstruation. That can be related to prostaglandin release during the ovarian cycle. So depending upon the amount of prostaglandin that is released will depend upon how much discomfort that patient may get. And it could also be related to the duration and amount of menstrual flow. Actually, these things most times kind of tend to go hand in hand. So not always, but some people have a lot of pain and discomfort, whereas they're not having a lot of flow. But usually if we're having a lot of flow, we're also having a lot of discomfort, and that's because of the prostaglandin release that both of those things are happening. So prostaglandins are going to modulate, they're going to help regulate and modulate the amount of pain that the patient's going to have. So what kind of a medication could we use in order to be able to manipulate the amount of prostaglandin the patient has and therefore be able to regulate hopefully some of the pain that the person's having and maybe some of the other symptoms? Okay, well, if you answered nonsteroidal anti-inflammatories, you'd be absolutely correct. So nonsteroidal anti-inflammatories will regulate prostaglandin release and therefore help to control some of the discomfort and symptoms that we see with primary dysmenorrhea. Secondary dysmenorrhea occurs when we have some other kind of pelvic pathology going on. So that person may have maybe cancer, or they may have some other thing going on, and then they're going to have this dysmenorrhea. So they're going to have the painful menstruation. Now that can occur anytime during the menstrual cycle when it's secondary because it's not being regulated so much by the menstrual cycle in the uterus. It's being more regulated by whatever's causing it, that secondary pathology. Primary amenorrhea means that the person is not having menstruation. A primary one would be the absence of menstruation by the age of 14. A secondary one would be an absence where the person is not having cycles in somebody who's previously menstruated. So let's look at some of the many causes that could cause a person to have amenorrhea. Over on the left-hand side, normal ovarian hormone secretion. Well, we could have pregnancy. I mean, that's going to stop the period, right? Okay, so we can have decreased ovarian hormone secretion with high gonadotropin levels, with low gonadotropin levels, or with low or normal gonadotropin levels. And you can see all of the different situations, all the different causes that could cause that to happen. We can also have increased ovarian hormone secretion. Okay, and you see that over on the right-hand side as to what might cause some of those things to happen. Let's take a look at another question then. A 45-year-old female is experiencing menopause. Which of the following would be expected to accompany this condition? Well, if you answered D, an increase in the FSH and LH, then you would be correct. The increases in these hormones is related to the decrease in the amount of estrogen and progesterone that are being produced. Normally there's kind of a negative feedback situation going on here in which the the FSH and the LH are going to be decreased in their secretion because of the estrogen and the progesterone being released. Polycystic ovarian syndrome is a situation where there is infrequent or no ovulation going on, and there's these little cysts that are growing on the ovaries. So they're interfering with how the ovaries are able to function and be able to release the egg. common cause of infertility, and many factors could be influencing this. It could be that the person is having problems with their insulin, they're having hypertension, or they're having problems with lipids, so the lipids are high or low. Dysfunction of the follicle development is also another common cause that would cause this to happen. So this slide is showing how some of these things may be connected to each other, and how the insulin resistance or the hyperinsulinemia can cause some changes in the hormones, which can lead to polycystic ovarian syndrome occurring. And again, polycystic ovarian syndrome, the patient has lots of cysts on the ovaries, which are interfering with reproductive function. There are some good pictures of this in your book, and on page 803 there's a picture of what a polycystic ovary looks like, and there's also a picture of what the ultrasound of a polycystic ovary would look like as well. Premenstrual syndrome is a situation where there's going to be abnormal hormone levels occurring in patients, and it maybe just in a lot of cases people are just more susceptible to the changes in hormones than other people would be. The other condition listed here is premenstrual dysphoric disorder as well. So these are mood disorders that are, and they're considered to be mood disorders by the American Psychological Association, that are occurring as a result of having these changes occur in the hormone levels. Now, this can range anywhere from a little bit of irritability all the way up to having some pretty severe mood disorders. So why would it be that one person is not having these kind of symptoms and another person has another? Or why is it that one person may be having mild symptoms like merely some irritability during their cycle, whereas somebody else is having clinical depression and suicidal ideation as a result of their menstrual cycle? Well, we think that it's probably because of the tissue response to the hormones more so than the amount of hormones. Certainly abnormal hormone levels can cause behavioral dysfunction, but it's more of a thought that it's the tissue response rather than the hormone amount. And you can see on the screen there, it also lists that there's greater than 200 physical, emotional, and behavioral signs and symptoms of premenstrual syndrome. So certainly there's a lot of different ways that this could manifest in the particular person. So a female patient presents with exaggerated feelings of depression, abdominal, back, and pelvic pain, and fatigue. Which of the following phases of the menstrual cycle is she most likely experiencing? Well, if you answered D, the luteal phase, you are correct. Premenstrual syndrome is most likely to occur during the luteal phase, right before the menstrual phase begins. Pelvic inflammatory disease is either an acute inflammatory and or infectious disease, in most cases probably caused by some sort of infection. We can also have other parts of the reproductive tract being involved. STDs are sexually transmitted diseases, and sexually transmitted diseases can migrate from the vagina to the upper genital tract and cause the person to have pelvic inflammatory disease. Oftentimes this can be more than one type of microbe that's causing the infection, and oftentimes patients who have sexually transmitted diseases have more than one type of disease at a time. But what happens is it's going to cause some severe dysfunction of the reproductive tract here. And we're going to see some changes occurring in the ovaries, some changes occurring in the structures around the ovaries. So you see some of the things here. Look at the picture on the right there. You'll see a lot of destruction occurring to the ovaries and the fallopian tubes. On the left-hand side, you see more of a graphic description here where the fallopian tube has become tender bilaterally, maybe swollen, etc., filled with fluid. We have these violin string adhesions that are going on there. This is all part of inflammation. Inflammation is causing the scar tissue to form, and it's usually the result of an infection. So we usually have an infection going on there, which is causing all of this inflammation to go. This will be treated with antibiotics, and hopefully we're catching it at an early enough point in time that the person's going to have absolutely normal function thereafter. Vaginitis is an infection of the vagina, which is often caused by sexually transmitted pathogens, and a couple are listed there. The acidic nature of the vagina provides some protection. Okay, so there is some protection. Just like in the upper GI tract, we have some protection from bacteria by the acid in the stomach. Well, the same thing is true here. We have an acidic nature of the secretions in the vagina, and that's hopefully going to keep bacteria from taking hold. We also have normal flora. Okay, now, but keep in mind that if something happens here to change the acidic nature of the secretions and or the normal flora. Okay, now we learned about this with the digestive system, that if we change the normal flora in the digestive system, then abnormal bacteria can take over. And the same thing can happen here. So if this person were taking antibiotics, say for example for a sinus infection, it could kill off the normal flora in the vagina, and then that bacteria or fungus could take hold and could develop an infection there. The Candida albicans is the thing that most people would call a yeast infection. Okay, and that would be, again, one of the common reasons for that to occur would be that we've killed off the normal flora by using antibiotics. Vulvitis is an inflammation of the external genitalia, and this could be caused by a variety of different things. It could be an infection, certainly it could be infection in nature, but in many cases it's going to be caused by having something that's irritating. So maybe that person is using clothes that are too tight fitting. We may see this in people who are runners. They just start running, or they go out and they run a long race, or maybe they're running a race when it's particularly hot outside and they're getting more rubbing than they normally would, more friction, and then that causes the inflammation of the genitalia. So a number of different things that could cause it. Certainly we want to avoid those things if at all possible, so that it doesn't happen again in the future. The Bartholin gland secretes mucus that is used to lubricate the vagina. However, the gland itself and the tracts coming from the gland can become infected or inflamed, and that's what causes a Bartholitis or also a Bartholin cyst. So the inflammation of one or both of the tracts is going to cause the problem here. Here what we're seeing in the picture is that the gland is swollen as a result of inflammation. Microorganisms usually are infecting the lower reproductive tract, and that's what's causing this to happen. Inflammation narrows the ducts and then leads to more obstruction, so we have mucus that's getting blocked and getting stuck there, and it can't move forward. Also, the infection is also producing secretions, which is causing the swelling and the discharge. The swelling of that gland is going to become painful. So just like a swollen gland would be anywhere, this is going to become painful. Certainly something this size that we're seeing here is going to be quite painful in nature. Pelvic relaxation disorders are situations where we have a loss of muscle tone caused by aging in most cases, but it can be caused by other things too. Women who've had many babies can have some disruption of the normal muscle tone in the pelvic area, and then that can cause some problems with having urinary incontinence and fecal incontinence, etc. But the loss of muscle tone in the pelvic area can also cause a lot of very serious disorders, and these can be classified as a cystocele, which is the bladder that is extending into the vagina, a rectocele, which is the rectum that's distending into the vagina, or we can have a combination of these things occurring. We can have vaginal prolapse or uterine prolapse, where the vagina or the uterus is actually prolapsing. It's actually extruding outside the body. What we're seeing in our two pictures here, first of all, is a cystocele, and that's the one at the top of the page there. You notice over on the left-hand side that where it's marked as bulge. Okay, that's the bladder, and the bladder is bulging down. Okay, it's bulging down and it's pushing tissue out of the vagina there. So it's pushing into the vagina. We're actually seeing tissue, and it's probably the wall of the vagina that's extruding here, but it's the bladder that's protruding through the wall that's causing that to happen. And that's because of a lack of muscle tone. At the bottom, we're seeing the same situation, except now look at the little bit of a difference there. Now we are extruding from, instead of extruding from the bladder, now we're extruding from the rectum. So the rectum is extruding through. So in our top picture here, here's the vaginal opening that's being highlighted. And then you can see over here, the bladder is extending out, and it's extending down over into the vaginal opening. Now on the bottom picture here, you see again, here's the vaginal opening coming up from the bottom. And now what we have is we have the rectum over here, which is impinging and moving into the area of the vagina, and that's what's bulging out on the exterior part. So we're actually seeing outside the patient's body, we're seeing this bulge out. So what we need to do is to rebuild that musculature in some way to try to keep that from bulging outward and causing additional problems and complications for our patient. Some proliferative kind of conditions that can also occur with the female reproductive tract include benign ovarian cysts, and benign ovarian cysts can be on one side usually. Typically what happens is just that we're having these little cysts that are forming there. Now enough of them forming on the ovary can start to interfere with ovarian function, but they're benign, they're not going to cause cancer. We can also have endometrial polyps, and this is a mass of endometrial tissue. This can cause the person to really have some severe types of periods and to have a lot of discomfort with their period, and that would be a situation where they may have to do some hormone therapy or surgery in order to be able to correct that. So this is an illustration of what an ovarian cyst might look like, and again, it's usually just on one side. Can be both sides, but usually on one side, and we have a lot of swelling occurring here, etc. It's usually non-tender, but it can definitely interfere with the patient's reproductive function. Endometriosis is a situation where, for one reason or another, maybe there's a hormone problem or hormone change or something like that, but there's endometrial tissue that's outside of the uterus. And whenever there's fluctuations in the hormones, like with a period, it's going to cause irritation, contractions, bleeding in those areas outside of the uterus, we're not supposed to have that kind of tissue outside of the uterus. So it can cause a lot of abdominal pain. It can cause a lot of discomfort during different points in time. Now, that'll eventually cause scarring around the uterus and could interfere with reproductive function. In adenomyosis, we have muscle tissue, connective tissue here, that's starting to form around our endometrial glands, and that's going to possibly cause some problems with dysmenorrhea and problems with our uterine function. Uterine fibroids are a fairly common situation where the patient has developed these fibrotic areas or benign tumors on the uterus itself, and this can cause bleeding and pain and a lot of cramping and things like that. So it can be very uncomfortable to the person to have uterine fibroids, and they can cause some abnormal bleeding at different points in time during the menstrual cycle that are just abnormal and not part of the normal menstrual cycle. And this slide here is just showing where some of the sites could be where we have endometrial implantations. So all those little black dots are little endometrial cells that have migrated outside of the uterus, and they're implanting throughout the abdomen, again causing inflammation and causing possibly to have some dysfunction. So obviously if these are implanting on the colon and on the intestinal system, we can get inflammation around the intestinal system causing the intestine to become inflamed. If we have these implanting on the fallopian tubes in the uterus, we can have dysfunction in reproductive function. One of the things, though, that tends to make this better is if the person becomes pregnant. Oftentimes that those cells will, because of the change in hormones, they will kind of shrivel up and could completely go away with a pregnancy. So pregnancy oftentimes is helpful in resolving endometriosis. Now this picture here is showing a patient who has uterine fibroids. So you can see all the little fibrotic tissue that's occurring, and there's a picture there that's showing how that fibroid could occur on the outside of the uterus, on the inside of the uterus, or in the uterine muscle itself. Then down at the bottom of the page there, it's showing a number of fibroids that have occurred in a patient's uterus that was removed from the patient. As far as cancer of the reproductive tract goes, we have cervical cancer that can occur, and this is obviously this is a big important thing that we'd like to catch early. Oftentimes with reproductive cancers is that we don't notice it. We don't find out that the person has cervical cancer or ovarian cancer until it's pretty far along. So that's why they're going to do the pap tests to look for the possibility of cervical cancer. Risk factors, HPV virus, I mean, that's a big one there. So other types of sexually transmitted diseases, HIV, etc., those all increase the risk of the possibility of cervical cancer. This is showing some pictures here of cervical disease progression. We're moving from a normal cervix all the way through, and we're starting to see some really severe changes in the cervix as a result of these cancerous tissues being formed. So as you go from left to right down in the middle of the page there, it's talking about the normal epithelium, and then you start to see we're starting to get that HPV infection, which is causing some abnormal cells to form. Now we're getting some mild cervical lesions, so we're starting to get those cancer cells starting to form there, where it says CIN1. We get to CIN2 now. We're having lots of cancer cells form, and they're getting a little bit deeper. CIN3, and we just have all cancer cells that are formed in that area, and we have cervical cancer occurring. Impaired fertility can also be a problem that occurs, and we define this as being the inability to conceive after a year of unprotected intercourse. Fertility can be impaired by a number of factors, so it can be something wrong with the male or the female or with both. So the male could have not enough sperm or could have slow sperm or immotile sperm. The women could have a number of different problems too, as far as what's happening in the fallopian tubes or producing eggs, or maybe not having a uterus that's able to allow for implantation to occur. So there's going to be some fertility tests that are going to be done. Structural tests, they're going to look at the structure of all of the reproductive organs. So we can do that with the CT scan, maybe do that with some other kinds of exams to just make sure that all of the structural organs are in place and where they're supposed to be and nothing's impeding them. Then we can also look at hormonal. So take a look at all of the hormones and make sure they're in the right places and what they're supposed to be doing, so that's not a hormonal thing that's causing the problem with fertility. Disorders of the urethra, we take a look at a couple here. Urethritis, where the person's having an inflammation. Usually, inflammation of the urethra is caused by a sexually transmitted disease. So that person has developed sexually transmitted disease, and that's causing the inflammation. If it's not a sexually transmitted disease, it could be the result of having a urologic procedure. You put a Foley catheter in a patient, you take it out, the person's going to have inflammation of the urethra from that catheter being placed. Foreign objects, etc. Okay, so all those things can cause inflammation of the urethra. Urethral strictures are actually a narrowing that is occurring of the urethra. Now here's a common situation where we get a narrowing of the urethra in a patient who has benign prostatic hypertrophy, where the prostate hypertrophies and narrows the opening of the urethra. Well, we can also get strictures of the urethra from other causes too. A fibrotic narrowing of the urethra that's caused by scarring, so maybe the person has had multiple catheterizations, had multiple irritations and inflammations of the urethra, which resulted in scarring. Could be the result of trauma, or could be the result of an untreated infection that we're starting to get strictures, and that's going to limit the amount of urine flow. So urine's going to back up into the kidney, and that backup could possibly cause post-renal type renal failure. Moving on to the male reproductive organs, we can have problems with or disorders of the penis. Phimosis is a situation where the patient is unable to retract the foreskin. This is usually the result of having a chronic infection. I guess poor hygiene might possibly do that as well, but we're usually going to see it in people who have some kind of infection or sexually transmitted disease. Opposite side of the coin is that we have paraphimosis, where the person's unable to be able to cover the glands with the foreskin. And again, same situations that are causing that to occur. Priapism is a situation where the patient has a prolonged penile erection. This is one of those things that you see on the ads all the time on TV for all of these drugs used for erectile dysfunction, and it says, if you have an erection lasting longer than 4 hours, seek emergency attention. And that's what this is. The medical condition is called priapism, and it's a prolonged penile erection. What happens is that blood gets into the penis, causing the penis to engorge, but blood is not able to drain back out. What's going to happen, because the blood is not able to drain back out, it's going to start to compress the vasculature, and the penis could actually become ischemic and necrotic. So it's a urologic emergency, and we want to get that person to the ER as soon as possible and be seen by a urologist. Probably what they're going to do is to give the patient some medications that are going to manipulate the vasculature so that hopefully we can get more blood flow to the penis. So these are some pictures of our previous problems that we talked about there, phimosis and paraphimosis. Some additional disorders of the penis. The first of which is Peyronie's disease, and what happens here is that we have thickening and scar tissue developing in the penis itself. So then when the person develops an erection, that tissue does not extend, it does not stretch, it doesn't bend, and so we end up with the erection being angulated and curved, and it's also called bent nail syndrome. But it results in the person having painful erections and painful intercourse because of this thickening of the erectile tissue that occurs. Vaginitis is an inflammation of the glands and the foreskin, and this can cause irritation and accumulation of smegma, which is just an accumulation of secretions or pus in the foreskin causing irritation. We can also have penile cancer, that's a possibility, although it is a rare kind of a condition. Two conditions that can happen with the scrotum are a varicocele and a hydrocele. A varicocele is a situation where we have inflammation or dilation of the veins in the spermatic cord, and that's going to cause the person to, and what's caused by is it's caused by having problems with the valves in the spermatic veins rather. Now, absent valves, well, they could be a possibility, but in most cases the valves become either inadequate or damaged, and it could be because the person is doing a lot of heavy lifting or something like that that's causing a lot of back pressure on those valves, just kind of like getting varicose veins anywhere else. And basically that's what it is. It's a varicose vein that is occurring in the veins around the spermatic cord. The primary reason why this would be important is, well, first of all, it can be uncomfortable. So it can be painful, and the patient may go to the doctor complaining of having some discomfort. But in most cases, where they find it is when somebody has a fertility issue and they're examining the male and they find out, oh, well, look, we have this varicocele here, and that's going to slow down the sperm because we have more blood dilated around the spermatic cord, and so it's going to overheat the sperm and cause problems with sperm. The other condition that can occur is called a hydrocele, where we have a collection of fluid that is occurring in the scrotum. Now, you may see this in patients in the hospital, especially in the intensive care unit, who are volume overloaded, that they get edema, not just in their legs and arms, etc., but they also get edema in the scrotum. Now, in those cases, that will go away. If we have a situation where the person just simply has an imbalance between the fluid secretion and reabsorption in their scrotum, that's going to be a little bit more of a difficult situation to be able to manage. But our patients in a hospital who develop swelling of the scrotum, in most cases, that's probably going to just resolve on its own. A failure of the testes to descend from the abdominal cavity into the scrotum is a situation that can occur in children, so that the testes just have not descended. Most of the time, the testes have descended into the scrotum before birth. However, especially in premature male infants, the testes may not have descended. Usually they're going to descend then within about the first month or so of life, and if not, then usually when a person reaches puberty. So it's a very rare kind of a situation that they have not descended by adulthood. Torsion of the testes is another situation that can occur. This is a urologic emergency. What happens with torsion of the testes is that the testes twists, and when it twists, it's going to twist, or it's going to clog off the vasculature going to the testes, and that will result in having necrosis of the testes. So that's why it's a surgical emergency. This typically happens in in boys who are about the age of about 12 or 13, maybe about 11 to 13 years old, where we can see the patient developing this. So this is showing the twisted spermatic cord, and then you see on the right hand side there that testis is starting to become kind of purple because it's becoming ischemic. So bad situation. We definitely want to get that person to seeing a pediatric urologist as soon as possible, because there may have to be surgical intervention that happens. They can try to untwist this at the bedside, but that's not a very it doesn't fix the problem very often, so it's not always very successful. So which of the following is true regarding torsion of the testes? If you answered a high riding testy may be noted, you are correct. So the test, and as we saw in that picture, the testy starts to ride up because the spermatic cord is twisting, so it's going to be pulling that testy up. So one may be higher than the other. Now, in most cases, in most men, that's generally going to be the case anyway. So that's kind of difficult to be able to determine, since they're probably not going to both be at exactly the same height to begin with. But a high riding testy is one of the things we can be looking at in order to determine that the person has torsion of the testes. Other disorders of the testes include architis, which is an inflammation of the testes. We can have complications or epididymitis that is causing this. Mumps is a very common cause. We can also have cancer of the testes, common in young people, young men. Painless testicular enlargement. So we start to see enlargement. We have to start thinking about the possibility that this could be a tumor, and we want to do something to take care of that. I mentioned earlier about benign prostatic hypertrophy, and the prostate runs around the urethra. So the prostate is running around the urethra, and it's a gland that produces or makes secretions to help lubricate the urethra and the spermatic gland or spermatic cord. So as people age, what can happen is the prostate starts to enlarge, and as it enlarges, it starts decreasing the size of the urethra. So it's like a donut around the outside of the urethra, and as it gets bigger and bigger and bigger, it starts squeezing the urethra, and now the person cannot empty their bladder. So it can be evaluated by a rectal exam, just by feeling, and can feel that the prostate is large. We can also do what's called a prostate-specific antigen, a PSA, and monitor the levels of that to find out how this prostatic hypertrophy is doing and whether or not a surgical intervention would be appropriate. With a surgical intervention, what they'll do is they'll actually go up there and just scrape away part of that prostate and pull it out. Now, they do this laparoscopically and with a, or I should say that it's not even laparoscopically because it's done transurethral. So they stick a catheter up the urethra, and then they go in with a laser and they remove that part of the prostate. So fairly non-invasive, although still you've got some disruption of the inside of the urethra, which can cause some bleeding and possibly blocking the urinary tract. Other problems with the prostate could be prostatitis, which is an inflammation, similar symptoms that we see with BPH. So we may see some swelling, we may see some decrease in urine flow, but in most cases, the thing that may make this a little bit different is prostatitis is probably going to happen faster than benign prostatic hypertrophy. Benign prostatic hypertrophy, the symptoms are going to come on over a long period of time, and for that reason, the person is probably not going to notice them very much until the urine output, the urine flow becomes very, very bad. However, with prostatitis, what's going to happen is that these symptoms are going to happen faster. So not over a period of a day or two, but certainly over a period of a couple weeks where the person's going to really be able to take note of them. Cancer of a prostate is another possibility, and this is one of the main parts of the male urinary tract that can become affected by cancer. The treatment for cancer of the prostate, and a lot of times we don't know. Okay, so the person comes in because they're not having a whole lot of flow, and we don't know if it's benign prostatic hypertrophy or cancer of the prostate. So we're going to have to do some additional testing there to make sure, and they're going to check for a cancer. They're going to check the PSA level, but we're also going to test for cancer markers as well to be able to find out whether or not this person does indeed have cancer of the prostate. Now, the treatment for cancer of the prostate is to do a radical prostatectomy, in which case what they do is they actually make an incision, and this is done down in the peritoneal area, and they're going to remove the prostate. We don't want to go up the urinary tract in order to remove it because we don't want to mobilize cancer cells into the urinary tract and possibly cause additional cancers. As far as disorders of the breast go, we can have galactorrhea, which is a persistent excretion of milk from the breasts, and in a woman who is not pregnant or not nursing. This can also happen in men. It's associated with hormonal imbalances, so that's what's going to cause that to happen. Breast cancer, a very common cause of cancer in women. So there's a number of factors. There's genetic factors, there's environmental factors, and lifestyle factors such as cigarette smoking that can have a big impact on whether or not somebody is going to be at higher risk for developing breast cancer. It's a leading cause of death in women aged 40 to 44. Mortality is only second to lung cancer, so high mortality. Black women are more likely to die. Now, there's a number of reasons for that to occur, but that's what the statistics currently say. The manifestations are that there's painless lump, maybe a dimpling of the skin or edema, and again, most people are not doing a detailed exam of their body on any particular day. So the chances that you're going to find a teeny tiny little lump are not very likely unless you're really making sure that you're being conscientious about doing your breast exams. So which of the following is not considered a cofactor for the development of cervical cancer? Okay, and if you answered that it was, okay, trying to get there you go. Breast cancer is not considered a cofactor. Okay, so breast cancer is not considered a cofactor for the development of cervical cancer. Smoking, chlamydial infection, HIV, immunosuppression, poor nutrition are all considered factors in cervical cancer development. Now, certainly you can have breast cancer that metastasizes, certainly. Okay, but breast cancer is not considered to be a risk factor, and typically breast cancer does not metastasize to the cervix, but maybe to other parts of the body and maybe the abdomen. Some other disorders, especially now of the male breast, we can have gynecomastia, which is an overdevelopment of breast tissue in the male. Usually a hormone imbalance is causing this, but it can also be medications that are causing this overdevelopment to occur. We can have male breast cancer, which happens more commonly after age 60. However, it is still pretty rare in men, so it's not nearly as common as what we see in women. Crusting, discharge from the nipples, common clinical manifestations. Chlamydial infections can happen in men or women. This is an infection that's caused by a particular type of pathogen, and the most common sexually transmitted disease in the United States is chlamydia. So this is a sexually transmitted disease. Along the same lines here, we can have a chlamydial type of infection that then moves on to develop additional lesions. So this is going from a localized infection of the reproductive tract now into a more systemic type of disease process when we get skin lesions, and then we can get necrosis and abscesses and infections that can actually spread to the central nervous system in that case. And can result in having a lot of variety of different symptoms. Other types of sexually transmitted diseases, just a bacterial vaginitis, that can be caused by a lot of different things, but typically is going to be a sexually associated condition, and bacteria is getting into the vagina as a result of having a sexual intercourse. Gonorrhea, another common type of sexually transmitted disease, usually requiring some kind of contact with the epithelial surfaces. Humans are the only natural hosts, so it's not coming from animals, or you didn't get bit by a mosquito or something like that and get gonorrhea. Burning with urination frequency and urethral itching are the classic signs that we see with gonorrhea. This is a systemic manifestation of gonorrhea, where we're seeing a skin lesion that is the result of having gonorrhea that has disseminated throughout the entire body, rather than being localized to the reproductive tract. A couple other types of sexually transmitted diseases. Syphilis is one here, and that can affect any body tissue. Often becomes systemic soon after infection and can be transmitted to the fetus. So we have the stages: the primary local hard kind of canker sore that is occurring, and then moving on to the secondary type of disease, which is going to be the systemic disease. And this causes a lot of long-term complications, can cause problems with mental retardation and central nervous system problems if it's not treated in its systemic manifestation. The phases of syphilis: there's this latent hidden stage where there's evidence of infection, but the patient's basically asymptomatic, so the patient may just kind of ignore it. Then there's the tertiary stage. This is the most severe stage, where we're getting lots of lesions and destruction of tissues. And then there's the congenital syphilis, where the patient is having some additional tissue destruction and can manifest in the first 2 years of life. This is something that the patient is receiving from their mother. Viral STDs include HPV. Okay, so that would be one common type of viral STD. HPV is a disease process, a virus that can cause, first of all, it causes warts, genital warts, and so obviously that can be uncomfortable. It can be, something that doesn't look very good, etc. But it increases the risk of cervical cancer, and that's why we're really concerned about it, is because it is so linked with cervical cancer. Treatment is cosmetic, it's not curative. And this is really true of any virus. We don't have a way to treat a virus. We can give antivirals, which decrease the viral load. And in this case here, they may give antivirals just to decrease the viral load and hope our own immune system can kind of catch up and take over. We can also have genital herpes. There's two different types. There's the simplex type 1 and type 2. Type 1 typically is going to be the type of situation that is occurring when you have a cold sore in the mouth. Type 2 is the type of infection that occurs when we have genital herpes. So the virus is going to be shed in secretions or open lesions. So secretions or open lesions are going to shed the virus, and that's how somebody else might receive it, especially if they have an open lesion. Kind of interesting the way that herpes is going to form here. We get an initial virus replication locally, and that's just going to spread to the cells right in that same area, and then it may be into sensory nerves, and can then be transmitted along the nerves and become latent until it's reactivated at a later period of time. So that's why we often see that people have an outbreak. And oftentimes the outbreak of the lesions is related to the amount of stress that they're under. So we can see more lesions during times of stress and less lesions during times when there's not stress. So that would be situations where this nerve part is going to be involved in how that is going to work. Parasitic sexually transmitted diseases, probably the most common one that we talk about is Trichomonas. Trichomonas vaginalis is a parasite that can adhere to the epithelial cells in the urethra, the vagina, etc. And it can cause additional destruction, additional inflammation of the reproductive tract, often coexist with gonorrhea. Okay, so oftentimes those two things kind of go hand in hand. And you're going to notice that oftentimes we have more than one type of infection that's occurring at a time with our patient. So this is going to be confirmed by a microscopic examination of vaginal secretions or by looking at urine, because we'll see shedding of our parasites, bacteria, etc. into the urine when the patient urinates. Pediculosis pubis lice, also called the crabs. Okay, so transmitted primarily by sexual intimate contact, and it's going to be a parasite that is going to be transmitted from one person to the next. Yes, it could be transmitted on infected bed linens, etc., just like any other kind of lice would be. So you definitely want to make sure you're cleaning the bed linens, etc. The louse has about a 25 to 30-day life cycle, and then there's some of the different stages that are listed there. Well, what happens though is the person is going to notice that they're going to have mild to severe itching, which could result in allergic sensitization if they are allergic to that crab louse, and then secondary infections caused by scratching. So primarily just it's going to be irritable and uncomfortable, and it is highly contagious. Well, thank you for joining me for Alterations of the Reproductive Systems. This is David Woodruff, and until next time, bye now.